Scleroderma is an autoimmune disease condition. Look at this picture, shows that hardening in skin and high resolution CT scan lungs for diagnosis. A detail going on. Introduction. Scleroderma is a chronic progressive autoimmune connective tissue disease characterized by abnormal growth of fibrous tissue leading to skin thickening and involvement of internal organs. It results from excessive collagen deposition, causing hardening and thickening of the skin and possible damage to the blood vessels, lungs, heart, kidneys, and gastrointestinal tract. While the disease is rare, it can be life threatening when vital organs are affected. Definition. Scleroderma is a chronic autoimmune connective tissue disorder characterized by excessive collagen deposition leading to skin thickening, vascular abnormalities, and possible internal organ involvement. It results from immune mediated fibrosis and microvascular injury causing progressive hardening of skin and tissues. Etymology. Derived from Greek word scleros, hard, derma, skin. Thus, scleroderma literally means hard skin, which reflects one of its most visible features. Epidemiology. Prevalence 50 to 300 cases per million population worldwide. Incidence 2 to 20 new cases per million per year. Gender, women affects 3 to 5 times more than men. Age of onset most common between age 30 to 50 years but can occur at any age. Ethnicity higher prevalence and severity in African American. Milder diseases more common in Caucasians. Types. A. Localized scleroderma affects skin and underlying tissue only. Morphia, oral or lineal patches of thickened skin. Linear scleroderma, bands of hardened skin often on lymph surface. B. Systemic sclerosis involves skin and internal organs. Limited cutaneous SSC, skin thickening restricted to hands, forearms and face, associated with CR EST syndrome. Diffuse cutaneous SSC. Widespread skin thickening, early internal organ involvement. Causes, exact cause unknown but believed to be multifactorial. One, autoimmune response causing collagen overproduction. 2. Vascular damage leading to tissue ischemia. 3. Genetic predisposition. 4. Environmental triggers, silica dust, solvents, viral infections. Risk factors. 1. Female sex, especially during reproductive years. 2. Age 30 to 50 years. 3. Family history of autoimmune diseases. 4. Exposure to silica dust, organic solvents, pesticides. 5. Viral infections. Possible triggers. 6. Smoking. Complications. 1. Pulmonary arterial hypertension, PAH. 2. Intestinal lung disease. 3. Renal crisis, scleroderma renal crisis. 4. Heart involvement, arrhythmias, cardiomyopathy. 5. Severe Raynaud's phenomenon leads to ulcers or gangrene. 6. Gastrointestinal dysmotility and malabsorption. Pathophysiology, step-by-step pathophysiology of scleroderma. 1. Genetic susceptibility plus triggers. Start the process. 2. Endothelial injury, apoptosis of endothelial cells. 3. Vasoregulatory imbalance, decrease NO-PGI2, elevate endothelin. 1. Thromboxane to vasospasm and platelet activation. 4. Leukocyte recruitment via VCAM1 or ICAM1. Selectines to perivascular inflammation. 5. Capillary rarefaction and endomemal proliferation. Biliary microangiopathy, ischemia. 6. Immune skewing, Th2, Th17 dominance, B cell activation to disease specific. Autoantibodies, ACA, ACL70, RNAP3. 7. Pro fibrotic signaling, TGF beta PDGF, CTGF, switching on. 8. Fibroblast to myofibroblast transformation with persistent survival. 9. ECM accumulation type 1 or 3 collagen elevate TIMPs, decrease MMPs to impaired matrix turnover. 10. Progressive fibrosis and vasculopathy to organ damage, skin sclerosis, ILD, PAH, renal crisis, GI, dysmortality, cardiac fibrosis. One line flow chart trigger endothelial injury, vasospasm, immune activation, TGF beta axis, myofibroblasts, collagen excess, fibrosis plus organ involvement. Signs and symptoms. 1. Skin thickening, hardening, shiny appearance, hypopigmentation, hyperpigmentation. 2. Vascular inverse phenomenon. 3. Musculoskeletal joint pain, stiffness, contractures. 4. GI dysphagia, acid reflux, bloating, constipation, diarrhea. 5. Respiratory shortness of breath, dry cough. 6. Cardiac palpitations, chest pain. 7. Renal hypertension, kidney failure. Medical diagnosis. 1. History and physical examination, skin changes. 2. Blood test. ANA, anti-nuclear antibody, anti-centromere antibody, ACA, anti-topoisomerase, SCL70 antibody, anti-RNA polymerase, third antibody. 3. Imaging, HRCT lungs, echocardiography, heart function. 4. Capillaroscopy, examination of nail folds, capillaries for abnormalities. Nursing diagnosis. 1. Impaired skin integrity related to collagen overproduction. 2. Impaired gas exchange related to pulmonary fibrosis. 3. Activity intolerance related to fatigue and dyspnea. 4. Imbalanced nutrition less than body requirements due to swallowing difficulty. 5. Risk for infection related to skin breakdown. Medical management. No cure, focus on symptom control and slowing progression. 1. Immunosuppressants, methotrexate, mycophenolate, mofetil, cyclophosphamide, 2. Vasodilators, nifedipine, sildenafil for Raynaud's and PAH. 3. Proton pump inhibitors, omeprazole for GERD. 4. AC inhibitors, captopril for renal crisis. 5. Antifibrotic agents in research. Nursing management. 1. Monitor skin integrity, use emollient and protect from trauma. 2. Educate about Raynaud's management, warm clothing, avoid cold exposure. 3. Promote gentle range of motion exercises. 4. Monitor respiratory and cardiac status. 5. Assist with nutritional support, small, frequent meals, soft foods. 6. Provide emotional support. Treatment options. 1. Pharmacological, immunosuppressants, vasodilators, corticosteroids, short term for inflammation, BPIs. 2. Non-pharmacological, physical therapy, occupational therapy, stress management, dietary modifications. 3. Surgical for severe complications, lung transplantation, digital sympathectomy. Psychosocial medicine. 1. Psychological counseling for cope with chronic illness. 2. Support groups for social interaction and shared experiences. 3. Education about disease progression and self-care strategies. 4. Vocational counseling if physical limitations affects work. Prevention. 1. Primary prevention, unknown causes. 2. Secondary prevention, early detection of complications and promote treatment. 3. Tertiary prevention, prevent disability via rehabilitation and lifestyle modification. 4. Avoid known triggers, cold exposure, smoking, occupational hazards. In conclusion, scleroderma is a rare but potentially life-threatening autoimmune connective tissue disease with variable presentations, early diagnosis, and a multidisciplinary approach combining medical therapy, nursing care, rehabilitation, and psychosocial support are essential for improving quality of life and reducing complications. While no cure exists, advances in treatment have improved survival and outcomes for many patients. Thank you. Have a nice day.